Reminders to all our attendees of the 12th Biennial Symposium. Before we get started, if you have any questions during any of the presentations, please feel free to type in your questions in the chat box and our speakers will answer them in the chat box. Or you can personally send us a message at pflhrd@biennialsimple@gmail.com. A friendly reminder to all our participants that microphones are muted by default during the entire presentation. And please kindly answer the evaluation form after the last speaker of the session, and link will be seen in the chat box. CPD units will be provided and your e-certificate will be issued through your email within 2 weeks. Thank you for being part of the success of this biennial symposium. For our next speaker, he completed his fellowship training in adult pulmonary and critical care medicine at the Philippine Heart Center. He is a fellow of the Philippine College of Physicians, Philippine Society of Critical Care Medicine, and a fellow of the Philippine College of Chest Physicians. He is presently the training officer in the Department of Medicine in General Trias Doctors Medical Center and the current chair in the Department of Medicine in Asia Medic Hospital and Medical Center. He is also a member of the Philippine Foundation for Lung Health Research and Development. It is with pride to welcome Dr. De Roxas to talk on the continuous positive airway pressure, bi-level airway pressure, and critical care non-invasive ventilation. The following are his objectives.
Good afternoon. Congratulations to the organizers for having this successful event despite the challenges related to the pandemic. It is my pleasure to discuss with you this topic about non-invasive positive pressure ventilation. These are the objectives of my lecture. I will discuss more on the principles of NIPPB management and differentiate some of its variants. Then I will present a few slides on the indications, contraindications, and possible complications of NIPPB. The mechanics and the physiologic effects of positive pressure ventilation in NIPPB is similar to invasive mechanical ventilation. The major difference is the use of tight-fitting mask in NIPPB with the goal to avoid the complications associated with intratracheal intubation. To better understand the mechanics of non-invasive positive pressure ventilation, let us look at what is happening during spontaneous ventilation. During inspiration, the thoracic pressure becomes more negative relative to the atmospheric pressure due to the expansion of the thoracic cavity as the inspiratory muscle and diaphragm contracts. This causes the air to flow from the atmosphere to the lungs. When the inspiratory muscle relaxes, the thoracic cavity and the lungs recoil back to its original size, thereby making the intrathoracic pressure more positive in relation to the atmospheric pressure, which causes the air to be exhaled out of the lungs. When an individual is placed on a positive pressure ventilator, these pressure changes becomes reversed. Intrathoracic pressure becomes positive during inspiration and comes back to baseline pressure or zero during expiration. So this may cause mainly physiologic and hemodynamic alterations in the pulmonary as well as cardiovascular function. This is the respiratory cycle in mechanical breath. The inspiration is initiated either by the patient or the machine. Once the breath is triggered, the ventilator then delivers the air to the lungs where the pressure is generated to reach the peak pressure throughout the inspiratory phase. The inspiratory phase is ended either when the patient ends the inspiratory effort or ended by the machine setting. Then expiratory phase follows where the pressure drops to zero or to baseline. Later, I will discuss the inspiratory and cycling sensitivity and the inspiratory time controls. And by setting these parameters, we can now manipulate the duration of the inspiratory as well as the expiratory phase so the machine can adapt better to patient's demand. So there are two types of positive pressure ventilation that can be provided to the patient. One is pressure cycle ventilation and the second is the volume cycle ventilation. In pressure cycle ventilation, the clinician set a specific amount of pressure and this will be delivered to the patient by the machine during the inspiratory cycle. The flow and volume generated depends on the respiratory mechanics. If the lung is less compliant like in ARDS or if there is high airway resistance, volume generated would be less. In volume cycled ventilation, the clinician set a fixed amount of volume to be delivered during inspiration, and the pressure generated depends on the respiratory mechanics. If the lung is less compliant, like in ARDS, or if there is high airway resistance, pressure generated will be high with the same amount of volume applied. In NIPPB, the pressure cycled ventilation is preferred because it has good leak compensation, where the flow increases to compensate for the leak to deliver the desired pressure. Due to the new developments of NIPPB, there are modes nowadays that can guarantee volume delivery even in the setting of pressure cycled ventilation. I will discuss that later as we discuss the different modes of NIPPB. I will continue to discuss the concepts and principles of NIPPB management as I present the variants of NIPPB. So there are two major variants. One is CPAP and the other one is BiPAP. And under these two variants, there are different modes. In CPAP mode, the patient is breathing spontaneously through a constant pressure that is delivered throughout the respiratory cycle. The respiratory rate, the flow, and the tidal volume depend on the patient's breathing effort. The changes in the intraalveolar pressure is similar to spontaneous breathing pattern, except that the baseline pressure is above zero. The continuous positive pressure that is applied to the airway throughout the respiratory cycle is similar to PEEP in intubated patients, which keeps the alveoli open and prevents alveolar collapse. CPAP is primarily helpful in improving oxygenation in patients with pulmonary edema. One variation of CPAP is CPAP with C-flex. C-flex enhances traditional CPAP by reducing the pressure at the beginning of exhalation. This is when the patients are often uncomfortable with CPAP. C-flex then return to the set CPAP pressure before the end of exhalation. The amount of pressure relief is determined by the C-flex setting and the expiratory flow of the patient. So the higher the setting, which can be set 1, 2, or 3, and the greater the expiratory flow, the greater is the pressure relief. Most of the studies comparing CPAP and C-flex shows advantage of the C-flex in terms of patients' comfort and increased tolerance and compliance in obstructive sleep apnea syndrome patients. However, due to the pressure release during initial part of the exhalation, this is not indicated for the treatment of acute respiratory failure due to pulmonary edema. Now, let us proceed to BiPAP or bilevel positive airway pressure. So the basic setup for BiPAP are FiO2, IPAP, and EPAP. But more advanced machines have these new added settings that can provide benefit and improve the comfort for our patients. With BiPAP, two different pressures are applied. One is EPAP, or the expiratory positive airway pressure, which is the baseline pressure equivalent to PEEP in intubated patient. Second is the inspiratory positive airway pressure, or IPAP, and the difference between the IPAP and the EPAP is the pressure support. So the value of the pressure support determines the amount of tidal volume that can be generated by the machine. We can start with an IPAP of 10 to 12 centimeters water pressure to maximum of 20 to 25. Pressures higher than 20 may lead to gastric distension and increased risk of aspiration. I told you earlier that the difference between the IPAP and the EPAP is the pressure support. So the higher the difference between the IPAP and EPAP, the higher is the pressure support, which is proportional to the tidal volume that can be generated. So to improve ventilation, we should increase the IPAP without increasing the EPAP. Now let us discuss EPAP. We can start EPAP pressure at 4 to 5 centimeters water pressure to maximum of 15. In patients with persistent hypoxia, we can increase EPAP by increments of 2 to achieve the desired oxygenation. However, we should also increase IPAP correspondingly to maintain the pressure support that will generate adequate tidal volume. In this graph, we have an EPAP of 5, an IPAP of 15, and a pressure support of 10. When the EPAP was increased to 10 without corresponding increase in IPAP, the pressure support decreased to 5. So we should keep in mind that when increasing EPAP, IPAP must also be increased by the same amount to maintain the same level of desired pressure. So this is the summary of the physiologic effects of IPAP and EPAP. So when you increase the IPAP, you increase the tidal volume, you decrease the respiratory rate, and improve the work of breathing, and decrease the partial concentration of carbon dioxide. When you increase EPAP, you overcome the obstructive apneas and hypopneas, you improve oxygenation and the functional residual capacity, and you counterbalance the intrinsic peak. So now we proceed with ramp time and rise time. Ramp time is the time needed to reach the pressures set by the clinician. So for example, if we set the pressure at 10 centimeters water with a ramp time of 10 minutes, the machine will start with lower pressure, then gradually increase the pressure over a period of 10 minutes before the set pressure is delivered. So this gives time to the patient to adapt to the applied positive pressure. Rise time, on the other hand, is the speed at which a breath is delivered to reach the plateau pressure. So a short rise time creates a sharp increase in inspiratory flow and a longer plateau, whereas a long rise time creates a slow increase in inspiratory flow and results in a shorter plateau. So adjusting the rise time to match the patient's demand for air increases the patient's comfort. Now we proceed with the trigger sensitivity. So to achieve the optimal patient ventilator synchrony, first to consider is adjusting the triggering sensitivity. There are two types, the inspiratory and the expiratory trigger. In inspiratory triggering, it could either be flow, pressure, or time, but in most studies, flow is preferred over pressure, especially in NIPPB, because it is more sensitive and responsive than pressure. So time triggering is the set backup rate in the time mode. Another way to improve patient ventilator synchrony is adjustment of the expiratory trigger. This dictates when the ventilator should end the spontaneous breath in relation to the inspiratory flow. Expiratory trigger sensitivity can be set from 5 to 80% of the peak inspiratory flow. In normal lung, the expiratory trigger sensitivity is usually set at 25%. Like in this graph, this is the PIF, or the peak inspiratory flow, and when the flow decreased to around 25% of the PIF, the inspiratory phase ends. So in COPD and other obstructive lung diseases where you need a longer expiratory time, the expiratory trigger sensitivity must be set higher to shorten the inspiratory cycle and to increase the expiratory phase. Now we proceed to the inspiratory time control. TI, or the fixed inspiratory time, defines the length of inspiratory cycle in time mode ventilation. If the breath is machine triggered, the duration of the inspiratory phase depends on the fixed TI set by the clinician. Next is TI minimum, or minimum inspiratory time. So this is the minimum time that the inspiratory pressure is delivered. This ensures adequate duration of inspiration in patients who are too weak to sustain adequate inspiratory effort and prevent premature cycling to EPAP. Next is the maximum inspiratory time, or the TI max. This is the time that the patient receives the inspiratory positive pressure. If we want to cut off the inspiratory cycle of the patient with prolonged inspiration or persistent inspiratory flow due to mask leaks, we can shorten the maximum inspiratory time. So this limits the inspiratory time to prevent reverse IE ratio, air trapping, and patient ventilator asynchrony. Now we move on to the different modes of BiPAP. This is the spontaneous mode, and these are the settings. So spontaneous mode requires that the patient has a spontaneous respiratory effort adequate enough to trigger the machine to deliver the IPAP. All of the breaths here are triggered by the patient. The first two breaths are cycled by the patient. As the inspiratory flow decreased to around 25% of the PIF, the inspiratory flow ended and the pressure dropped to EPAP as the expiration begins. On the third breath, the set TI minimum cycled the breath. We see that the patient's effort and the inspiratory flow ended prematurely, but since we set the TI minimum to this point, the machine continuously delivered the pressure support up to this point. So in case of a very weak patient who cannot sustain adequate inspiration, TI minimum can prevent the premature termination of the inspiratory phase, which could lead to hypoventilation. So that is the value of setting the TI minimum. In this breath, we see that the patient's effort and the inspiratory flow are prolonged, but since the TI max was set at this point, the prolonged inspiratory effort, which could lead to prolonged inspiratory phase, was arrested. So prolonged inspiratory flow can happen in patients with increased airway resistance or when there's excessive leak in the interface. Hence, TI max can limit the inspiratory time in this situation. So we can set a shorter TI max to shorten the inspiration to give time to a longer expiratory phase. This is the ST mode or the spontaneous time mode. The spontaneous breath is similar to the S mode where the patient triggers and ends the breath. And we can also manipulate the inspiratory time by setting the TI minimum and TI maximum during spontaneous breath. The difference is that a set backup rate is present. When the patient's respiratory rate falls below the set backup rate, or when the patient develops apnea, a mandatory breath will be delivered with the fixed inspiratory time. The next mode is the PAC or pressure assist control. So these are the settings for the PAC. Here the patient may trigger the IPAP, but has no control over cycling. Cycling in PAC is controlled by the fixed inspiratory time. So if the patient's rate decreases below the set backup rate, the machine triggers the IPAP, just like in ST mode. So the major difference between PAC and ST mode is that regardless of patient's inspiratory effort, the inspiratory time is fixed as set by the clinician. So you cannot set the TI minimum or the TI max in pressure assist control mode. The next mode is AVAPS or average volume assured pressure support. So this is an NIV technology to ensure delivery of a fixed tidal volume in pressure cycle ventilation. So to easily understand AVAPS, let us compare it with the ST mode. In the ST mode, we set the IPAP, the EPAP, and the difference is pressure support. But in ST mode, the pressure support is fixed. In AVAPS, we still set the EPAP, but instead of one IPAP target, we set two IPAP targets, a minimum and the maximum P. So this is the main feature of AVAPS, the target tidal volume. So the ventilator in AVAPS adjusts the pressure support within the range of minimum and maximum pressure to achieve the target tidal volume. So in the control panel, you will see that there is a tidal volume, an EPAP, and the minimum and maximum pressure. So in this example, the minimum P is 10 and the maximum P is 20. The machine adjusts the pressure support to achieve the target volume of 500 ml. And to do that, you will see in the monitoring that the pressure needed to deliver the 500 tidal volume is 17 centimeters water pressure. So here you will see that the same amount of pressure generated different amount of volume due to changes in the patient's lung mechanics. So a decrease in tidal volume may be due to decrease in lung compliance or increased airway resistance. In ABAPs, this decrease in tidal volume can be corrected by automatic adjustment of pressure support within 1 minute of the initial change in volume. So in this case, pressure support increased and the tidal volume subsequently returned to target. But the adjustment in pressure support should be within the range of the minimum and maximum pressure. So this is the setting for ABAPs. The maximum IPAP is 20 to 25. The minimum pressure or minimum IPAP is equals to EPAP plus 4 centimeters water pressure. Another way of choosing minimum pressure is to observe the EPAP, IPAP, and exhale tidal volume while on ST mode, then set the minimum pressure equivalent to IPAP on ST that generates a value close to the target tidal volume. So when increasing EPAP, minimum pressure must also be increased by at least 1 centimeters water above EPAP. So now we proceed with the indications and the contraindications of CPAP and BiPAP. So this was taken from a relatively old article of Mehta and Hill in 2001. I think nothing has changed when it comes to the selection criteria when to apply an NIB to patients with COPD and acute respiratory failure. These values are usually used as inclusion criteria in most of the studies involving NIB. So first, we should identify the patients who are in need of ventilatory assistance. So those patients with symptoms and signs of acute respiratory distress, those with moderate to severe dyspnea, with RR more than 24, use of accessory muscle, and paradoxical breathing. And when you look at the gas exchange, PCO2 more than 45, pH of less than 7.35, and PF ratio of less than 200. So once you have identified those patients who are in need of ventilatory assistance, then step 2 is to exclude those who are at increased risk of NIB failure. So these are the contraindications: patients on respiratory arrest, patients who are medically unstable with hypotensive shock, uncontrolled cardiac ischemia or arrhythmias, those who are unable to protect the airway with impaired cup or swallowing mechanism, as in stroke patients, excessive secretions, those who are agitated and uncooperative, and patients with facial trauma, burns or surgery, or any anatomic abnormalities that can interfere with a good fitting of the mask. Now, these are the indications for NIB in different types of acute respiratory failure. So this was taken from the 2017 ARS ATS guidelines in the use of NIB and ARF. So the recommendations in these guidelines were divided into strong and conditional recommendations, where strong means that most individuals should receive the recommendation because it is backed up with strong evidence, and weak or conditional, which means that although there is a low quality of evidence, the clinician has the final say to decide on its use based on the patient's circumstances. So the guideline strongly recommends NIB in COPD exacerbation and COPD patients who is rapidly deteriorating and considered to require endotracheal intubation. So there's no limit or lower limit of pH below which a trial of NIB is inappropriate, but a lower pH has a higher chances of failure. So we have to closely monitor these patients. And for the conditional recommendations, ARF is indicated for cardiogenic pulmonary edema Although this recommendation does not include patients with acute MI because there was a small study which showed an increase in mortality in this subgroup where NIB was used. It is also indicated or recommended in immunocompromised patients with ARF, acute respiratory failure in post-operative patients, patients with terminal cancer, chest trauma patients with acute respiratory failure, and it is also recommended to facilitate weaning from mechanical ventilator in patients with hypercapnic respiratory failure. So the benefits of NIB use in these patients were the decreased need for intubation, the decreased incidence of pneumonia, and the decreased length of ICU stay and decreased mortality. So for bronchial asthma, there was no recommendation made because pooled analysis of evidence failed to show improvement in mortality, rate of intubation, and length of ICU stay. For acute respiratory failure due to viral illness and even for COVID ARDS, there is a limited number of studies to make a recommendation. And the issue here is the potential increased risk of viral spread with NIB use. Now, these are the complications. So in this study, the complications were categorized into mass-related, and the most common is discomfort, facial erythema, and followed by claustrophobia, nasal bridge ulceration, and acneiform rash. For the air pressure or flow-related, most common is nasal congestion, sinus ear pain, nasal or oral dryness, eye irritation, and gastric insufflation. And there is also that complication of air leaks, and also a few major complications like aspiration pneumonia, hypotension, and pneumothorax. So this is my last slide, and thank you for listening.
Thank you, Dr. De Roxas, for the brief and complete discussion. Now, as a way of our appreciation, the Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center, Division of Pulmonary and Critical Care Medicine, we would like to show our gratitude and present our certificate of appreciation to Dr. Ronald De Roxas as a speaker for imparting his knowledge on continuous positive airway pressure, bi-level airway pressure, and critical care on invasive ventilation during our 12th Biennial Symposium today, September 15, 2021. Signed by our President, Dr. Cesar Ligo, Dr. Eileen Guzman Manzon, the head of the Division of Pulmonary and Critical Care Medicine, and the members of the organizing committee. Thank you, sir. With that, we would like to thank our speakers for imparting their knowledge, and to our audience, we appreciate your time and for being with us today. And we would like to invite you to the Boehringer Ingelheim Dinner Symposium after the last session. We would like to remind you that we will have a 15-minute break before our next postgraduate focus chat would commence. Please stay tuned and thank you.